background about myself and about PMC. I have a clinical background as a nurse midwife. I practiced as a midwife, did both home and births and hospital birth in Connecticut, and worked as well in freestanding birth center model. And I've been out of clinical practice and working on sort of system level efforts, really mostly around midwifery, doulas, and childbirth education, and some other areas of practice as well. So we're really excited to have been able to work on this initiative with Connecticut and to be part of moving forward Medicaid Husky payment for doulas in the state. So that's a little bit about me. I will pass it over to Claudia, who's been our project lead on this project, to say hello as well.
Hi, good afternoon, everyone. My name is Claudia Jennings. As Amy noted, I've been the project lead for PMC on the Doula Integration Project, and my background is in practice management. I worked for a freestanding birth center nurse midwife practice for nearly 7 years and wore all sorts of administrative hats, and that's the lens that I bring to this work. And I will pass it to Darlene.
Good afternoon, everyone. My name is Darlene Turner, and I am a doula with primary maternity care. My background is as a physician assistant in general internal medicine and women's health. And I started doing doula work in about 2009, have done a lot of work around high-risk pregnancy, and have then moved into curriculum development and doula programming implementation, mostly in the community-based model. And that is the lens I bring to this project. Nice to see you.
Great. So we'll go ahead and get started. What we're talking about today is the maternity bundle payment initiative, which will share more about what that is for folks that that's a new phrase for. So this is the outline. We're going to talk a little bit at a high level about the Husky Health Program and how maternity care services fit in. We'll talk about the planned payment pathways for doulas. Many of you are aware that legislation was just passed and signed by the governor last week that also affects doula payment. So we'll talk a little bit about both the bundle payment and the legislative pathway and compare how those will unfold. And then we're going to take a closer look at the bundle, because that's what the focus of our work with the state has been, to really operationalize what this will look like in the bundle payment pathway. And we have developed some tools to help integrate doulas into practices that are participating in the bundle payment. And we'll walk through some of those tools with you toward the end. I'm just going to remind before we get move forward for folks to please mute if you have joined and are off mute. I think that that's the default state. So hopefully we can all work together to stay off of mute. If you're not speaking, go ahead and use the chat if you do have questions. We'll try to get to them as we go, but we will certainly have time at the end to address any questions. And just be aware as you participate, whether it's through the chat or verbally, that we are recording this session, and it will be an enduring training resource for others. So keep that in mind as you decide what you want to share in this space. So we'll go ahead and get started to the next slide. So we just wanted to give some background for folks that haven't worked with Husky, which is the state's Medicaid program. So we can continue to the next slide. This is a program that covers more than 40% of births in the state. So Connecticut is a little bit unlike other states in that we have just one provider for the Medicaid program. There's not multiple companies that provide Medicaid programs. So everybody's under Husky Health, and there's a few different variations of it. But overall, it accounts for 15,000 births annually in the state. And it covers low-income individuals. In our state, that includes undocumented immigrants, so regardless of their immigration status. And pregnancy changes the income levels, so you can qualify for Husky in Connecticut and in other states as well at a higher income level than for regular Husky, or in the non-pregnant time period. So it covers low-income individuals. There's no cost sharing for pregnancy-related care. So appointments with the doctor or midwife, the hospitalization for the birth itself, and the doulas as they come online as part of the benefits, there will not be cost sharing, meaning that patients or people don't have to pay co-pays or deductibles as part of their part of it. The Husky program already has a number of programs that are directed at pregnant individuals in the state. Most importantly is the high-risk perinatal care management program, which provides education and service navigation for people with certain medical and social risk factors. And there are rules, as there are in every state, for who can bill Medicaid and be reimbursed for services. And until the legislation that was just passed is fully implemented, there has not been an existing mechanism to bill Husky for doula services. So it required an act of legislation to get to a place where we can directly bill Husky for doula services. And that has to do with sort of how provider types are established in the Medicaid program, both at the state level and federally. Next slide. So just a little bit about who's covered. Like I said, it's about 40% of the births in the state, and that is disproportionately includes certain groups. So we know that about close to 18% of pregnant Husky members have a primary language that's not English. The most common is Spanish, but we see a range of other languages spoken around the state by pregnant people. Of course, everyone is born, so everybody, in any given population will be part of the pregnant population that we have to care for. So that's who we see in Husky. Next slide. Also race ethnicity, the efforts to get more information about race and ethnicity of Husky members is, continues to unfold, but we know that Black people make up, we do not have the numbers on this slide, but you can see the largest slices of the pie are the Black and Hispanic individuals, as well as white non-Hispanic people and people who the DSS does not have ethnicity information about. Next slide. And so we wanted to emphasize that this whole program, the bundle payment program that we'll be talking more about, and Husky's overall approach to pregnancy care is really about promoting equity, and that includes the emphasis on increasing access to doulas as part of this new initiative. And so we wanted to speak specifically to how we see doula's role in promoting equity through the Husky Health program. We, just by virtue of making this available to more individuals, is itself supporting equity, because up until now, this has been really a cash pay service that only people that have the funds to pay for doulas, which are expensive because doulas, it's a profession and it's a demanding profession. So to pay doulas a wage that is commensurate with the effort and training and responsibility that they do is expensive. And until now, there hasn't been insurance coverage for that in Husky or in commercial or employer sponsored plans. And so just by correcting that and by leading the way with Medicaid coverage is promoting equity in the state. We also believe that doulas, because they are community-based in many cases, because they come from the communities of the people who are birthing in the state, and because there's such a strong evidence base for doula support in general to improve outcomes, to improve experiences, and to do that through activating and supporting pregnant individuals and helping them use their voice to, have care that is appropriate and respectful and that supports their bodily autonomy. So we are excited to bring more doulas into the fold through this initiative. Also want to just say that we understand that doulas can't fix everything about the system, and that this is part of a multidimensional effort to address racial disparities and inequities in our system. Next slide. So I'm going to pass it to Claudia for this next section.
Thanks, Amy. So I'll talk about the different planned payment pathways and what doula payment options will be available in the near future. Next slide. So there will be two options for payment that are forthcoming. The first payment pathway will be through the bundle payment, which is what we're predominantly talking about today, and it will begin in January of 2024. doulas will be able to partner with providers who participate in the maternity bundle and provide services through that partnership. And in this case, doulas will be paid by the provider, not directly by Husky Health. The eligible medical practices that can participate in the bundle will be those that have 30 or more Husky deliveries, and those that qualify will be automatically enrolled in the Husky bundle. And that means that they will receive per member per month payments that are meant to offset the costs of providing doula services. So again, that means that providers that meet that 30 birth threshold and are certain provider types, which is predominantly OB/GYNs and nurse midwives, will be getting per member per month payments that are earmarked for doula services. It will be based on a trigger claim that would be when a patient is in their second trimester of pregnancy, so that they're not starting to make payments for people in their first trimester when there's still a risk of miscarriage or the option of termination. So it is starting in the second trimester. And then after the patient's maternity episode is complete, providers will have their per member per month payments reconciled to their actual doula usage to ensure that they were paid for the doula services that they used or that they subcontracted out to folks like you. And if the provider doesn't end up using doula services at all, the money that they received from Husky Health that was earmarked for doula services will have to be given back to Husky, because it will be redeployed to a practice that did work with doulas. So we just wanted to, help all of you understand that that money really was emphasized by Husky to be dedicated to doula services. And although the mechanism is through a per member per month that goes to every practice or virtually every practice, it will ultimately be allocated to those who do use doula services. The second pathway is through direct or fee-for-service contracting, and DSS plans to develop this payment pathway soon, but we don't have a specific timeline. So as Amy talked about earlier, some of you are probably aware that legislation was recently passed and signed into law that gave the Connecticut Department of Public Health the authority to establish a certification process for doulas. And that certification is not required to practice as a doula in the state, but it will serve as the framework for Husky Health to use to credential doula providers. And the certification would be required if you want to work directly with Husky Health members outside of the bundle payment, but enroll with Husky Health as a provider. So next, let's look at a couple of factors to compare those payment pathways. So through the bundle payment, you as a doula would not be enrolled directly with DSS. You would be enrolled with the provider, and the provider would set what their enrollment parameters are. That certification that you would need to meet would again be through the provider. We do recommend that providers choose to rely on DPH certification for determining who they are going to call a doula and who is not a doula. That certification process, if you're not aware, was developed through a stakeholder group that had representation from doulas in Connecticut, medical providers in Connecticut, and other interested stakeholders, and was a really thorough process that we think is what providers should rely upon instead of establishing their own. But it is up to them. It's ultimately not stipulated by Husky through the bundled payment what that certification process looks like. The population served through the bundle payment would be any Husky member that is able to participate in the bundle payment. So that means that that Husky member would need to go to a practice that has at least 30 or more Husky births. And then there are some limited exclusions that would take a member out of participation in the bundle. And I should also note that FQHCs, which are federally qualified health centers, it's a type of maternity care provider, are not eligible to participate in the bundle, at least in year one, because of some operational issues with determining how payment could be made. So from you as the doula's perspective, the payer through the bundled payment is the provider. So the provider would be getting money from DSS, but ultimately you as the doula will be paid through the provider, not directly from DSS. The payment rate that has been set is $1,200 that's paid directly to the provider. We do anticipate that providers will take a portion of that to cover the administrative overhead of administering the program. And so we would expect that what a doula would receive would be some slightly less than $1,200, and each practice would be able to set their own rates. And the nature of the relationship could be different depending on the practice. And so some practices may look into hiring doulas that would be employed and like W-2, paid hourly, and other practices might look at an independent contractor relationship where they are paying you in a more traditional, doula payment rate where you have a set rate for certain services. The covered services through the bundled payment are 4 prenatal or postpartum visits and one rate for attending the birth. And those visits can float between the prenatal and postpartum period. So Husky is not requiring that those visits happen like 2 prenatally, 2 postpartum. They can float. They could all be postpartum, all be prenatal, or any combination in between. And the services aren't all required. So someone could have just postpartum services that they do, or just the birth. All of it is separate. It will really be up to providers to decide what their program looks like. And, our hope and our intention is that providers will be able to work with the doulas that they can build relationships with, and together collaboratively define what that looks like for that doula practice and the medical practice. So in switching over to the right-hand column in the direct fee-for-service model, you as the doula would be enrolled directly with DSS. That means that you will likely have to meet any standard requirements that DSS has for enrolled providers. And you can also expect to have some specific requirements for doulas as well. The certification would be through DPH. That will be the certification that Husky will rely on, as we've discussed. And the population served would be any pregnant Husky Health member. There won't be the same restrictions that would be in place through the bundle payment because of some of those administrative exclusions that exist. The payer will be DSS if through fee for service, and that means that you as the doula will be submitting claims for the care that you provide, or likely submitting claims, and then engaging in a revenue cycle management process that any medical services provider engages in right now, where you might have denials that you're managing and needing to work with any claims that are having a hard time getting through the system. And the payment rate and the covered services are yet to be determined, but Husky will be communicating that as they identify those different services. Next slide. So next, let's talk a little bit more about the services that are included in the bundle. Next slide. So the maternity bundle really incentivizes providers to better integrate clinical and non-clinical care. And by including non-clinical services in the team-based environment, DSS and Husky believe that the goal of the bundle can better be achieved, not by one single member of the team, but really by the combined effort of multiple care team members working in coordination with one another. So doulas can focus on aspects of care that providers often lack the time or expertise to provide, things like education, connecting to the right community supports, and providing hands-on and continuous bedside support for pregnant people. DSS recognizes the importance of the role that doulas can play in remedying disparities and really positively impacting outcomes, not just the actual outcome of the birth, but also the member's experience of their birth. And we know that doulas can play a really important role with that experience as well. But as Amy mentioned, we have continued to highlight through this project that doulas are not the sole solution to these issues of poor outcomes and disparities in care, but we know that they can play an important role to move the needle, and that it's a very positive first step that doulas will be able to be paid through Husky Health so that we can more meaningfully incorporate them into Husky members' care. So next slide, let's take a look at the roles of DSS, doulas, and providers in the bundle payment doula integration. So first, let's take on DSS. So DSS will support the effort by providing the payment authority and paying providers through the bundle payment program via a per member per month. They will determine the reporting requirements for doula services, and they'll set the fee schedule that's specific to doula services for the amount that's paid to providers. As part of the doula implementation, DSS is providing draft supporting materials as part of an integration toolkit, which we'll talk about more later on in the presentation. And as we talked about earlier, DSS is also pursuing the parallel direct payment pathway for doulas that will rely on DPH certification. These payment pathways do have key differences, but where they can be aligned, there's motivation to do so. Excuse me. Next, for providers, providers are responsible for creating the relationship in collaboration with doulas. And I really want to emphasize that we think it's important that providers and doulas work together on this effort. Providers can define what type of doula program they want to create, whether it's a subcontractor relationship or employed, and what qualifications the doulas they work with will need to have. We recommend that they rely on DPH certification, but some providers may choose to set their own standards. And providers should refer their patients to doula services. They'll set their own payment rate, and they will be supervising the doula's work, which is part of the statutory language that's required through this pathway. And we'll talk more about that later in this presentation. Providers will ultimately also pay the doulas when a patient uses doula services in accordance with their practice level doula arrangements. And providers will also be responsible for collecting and reporting the doula outcomes to DSS via the maternity bundle notification form. Last, doulas will engage with providers directly, submit the encounter information and outcomes to the provider as necessary and as they agree on, so providers can fill out the notification form, and they'll invoice the provider directly for any services. And the doulas will also be responsible for reviewing the competency requirements and ensuring they meet them. But providers should also review this information as well, since they'll be setting the requirements. Next, I'm going to pass it to Darlene to talk about the doula role.
Oh, hi, everyone. Let's talk now about how doulas will be active in this program. So doulas participating in the bundle will provide non-clinical physical and emotional support. So it's not going to be anything new. It's going to be doing what we regularly do. They will educate about the common courses of pregnancy, labor and delivery, and postpartum, and help clients prepare for their pregnancies and their parenting journeys. We'll be assisting pregnant and birthing people with access to community and/or social services, which may be beneficial to their pregnancy and childbearing experiences. They're there to be a continuous and consistent source of non-judgmental support. So again, just what you're already doing, and helping clients to advocate for themselves, to speak up for their healthcare needs and for the needs of their babies. Next. So let's talk about this supervision thing. Doula services will be rendered and reimbursed under the medical provider supervision through the bundled payment. And what this means, what provider supervision means, that the medical provider will set an overall care plan for the client. So we will be working as a doula under that overall care plan. The medical provider will hold the professional administrative responsibility for your services. However, it's up to doulas to use their own professional judgment in performing the services and to work to the full extent of the scope of their practice. So again, you're pretty much going to work as you normally would, but just in concert with a provider. Next slide, please. What's involved in provider supervision? Again, their responsibility is the organization and coordination of the patient's maternity care. So ordering whatever tests and treatments that are necessary, guidance on patient care that the doulas can provide, which is pretty much going to be outlined, and I would say negotiated in the job description and policy prior to taking on the position with the practice. Respect of the doula role and doula scope of practice. And it's up to you and the providers to negotiate whether you will be an independent 1099 contractor or an employee with the practice. Sorry about that. What we are not expecting to be involved in this relationship is a very restrictive oversight of the doula-patient relationship. we're all aware that the benefit of doula care comes from the relationship between the doulas and the clients. So we're really pushing and advocating that that relationship be maintained and kept in the trustful interaction that it is, and that there aren't going to be significant limitations on doula scope of practice. Again, that these areas should be outlined and agreed upon prior to engaging in the contractual agreement. Next, please. Who is eligible to participate? So doulas who are eligible to participate are those who want to work with supporting childbearing Husky Health members. It's not that everyone has to do this. It is just those people who are really wanting to serve Husky Health members. They are also doulas who can demonstrate that they meet the core competencies set forth by the Connecticut Department of Public Health, and we'll talk about that in just a moment. And those that are interested in working in a contractual relationship with a participating practice that provides maternity care services. That is something you are going to have to determine, but I think it's very important to understand that if you choose not to engage in the maternity bundle payment program, that does not mean that you cannot operate as a doula and maintain your current practice as you are right now. These are standards that are just for those folks who are going to work within the bundle. Again, best practice is not necessarily required, and each practice will set their own standards, and that will come between you and the practice and the providers within the practice. And there are going to be some proposed standards that we have, and we'll talk more about that in the toolkit. Next, please. So what's covered? We talked about there are going to be 4 either prenatal, postpartum visits. It can be 2 prenatals, 2 postpartums, 4 prenatals, no postpartums, what have you, and the labor. But within that, when we're talking about the prenatal and postpartum visits, what's covered is childbirth education, birth and postpartum planning, personal advocacy and communication skills, comfort measures to relieve the common aches and pains of pregnancy, labor, and delivery, newborn care education, and routine lactation support. Again, we're providing continuous support during labor and delivery and non-medical comfort measures. One thing that is important to know and for everyone to consider, the doula services that are reimbursed are limited to the services covered by the supervising practice. So if you have another skill or area of expertise, for example, belly binding, placental encapsulation, massage therapy, etc., you may perform these services with your clients, but you cannot bill for them through the bundle. So again, really go through with your supervising physicians and understand what are the covered services and what aren't covered services, because if you provide a massage to your client, that's not a covered benefit under the Husky bundle, and you cannot get reimbursed for it through the bundle, nor can you then ask your client to pay for that separately. So these are some things to consider and talk with and learn more about, and we'll have a bunch of tools and information sheets for you through this bundle. Next. Again, the pay rate. We talked about there being 4 prenatal or postpartum visits. It's not fixed. So as we all know, sometimes you have a client, they only need 1 prenatal, but they need a lot more help postpartum and vice versa. But in total, prenatal and postpartum visits, you will be reimbursed for 4 at a rate of approximately $100 per visit. Attendance at the labor and birth is reimbursed at $800, and the maximum reimbursement for the pregnancy encounter is $1,200. Now, again, what is the administrative rate from the practice? That you have to negotiate with the practice, and is something to be determined. Again, the limit is per pregnancy, not per doula. And we want to make sure people understand that if a patient switches doulas during pregnancy, the total number of allowed visits will still be the 4. So if she had 2 visits with the first doula, she can only have 2 visits with the second doula. So you need to know that if you pick up a client from another practice, you need to know and understand how many visits she's already had. Next slide, please. The integration toolkit. Next. Is this me, Claudia? Am I going to keep going?
You can keep going, or I'm happy
Okay.
to do
Nope.
it.
I just want to make sure before I started talking. Okay, so the Doula Integration Toolkit has 3 components, and we have resources for you to read and look at, model policies and templates that you can mimic to adapt to your practice. And the toolkit is going to be publicly available, that you can use these resources, you can copy them, you can adapt them, but we wanted something that people can have something to start off with, that you weren't starting from scratch. Next. So the toolkit is composed of, there are some form templates, and then there are some model policies. So in the form templates, there's a model referral form, a reporting form, an invoice, and a satisfaction survey. And again, you and your supervisor practice, you can decide that you like them and you're just going to use them as is, or that you're going to refine them to meet your needs. The same thing with the model policies. There's a model doula job description, hospital provider doula policy, grievance process, and fee schedule. And again, these are just so that you don't have to start from the ground up. And the access to the toolkit will be available starting mid-July. Next. And again, in the resources, there will be, it'll be a full toolkit, but you'll notice that certain things are for the members, some are for the providers, and some are for the doulas. And for the members, there's a FAQ sheet, and there's templates and forms for prenatal education. For providers, there's a referral workflow with a visual aid, FAQ sheet, payment flow example, what the doula training programs offer versus the DPH core competencies, educational campaign materials, and this webinar recording that we did for the providers. And for the doulas, there's a referral workflow with the visual aid, FAQ sheet, and again, this webinar recording. Next. And I think this is Claudia here, how to use
it is. Thanks, Darlene. So each of the documents in the toolkit has an introductory section with a little background on the bundle payment program. We wanted to make sure that if you were, accessing just one document, you kind of had a little bit of context for the program as a whole, and then some additional context for the document itself to set the stage so you understand what you're looking at. And what we recommend is that you look at the documents, consider how it could apply to a partnership that you're thinking of, and making any changes that you see fit to fit into your needs. The documents are really meant to be a starting place that can be customized to each specific relationship. We know that there's interest from providers, and we really think that a motivated doula could pull together some of the model documents and approach providers that they already have a positive relationship with by bringing a packet of the documents to the provider and asking if they would consider working together on behalf of their Husky members. I noticed that in the chat, there's been some questions about how doulas can find providers to work with. And I think what we can share is that we know that providers have a kind of the same question, but framed slightly differently, which is how can we find doulas that we can work with? And we know that there's a need for venues for providers and doulas to connect, and I think that the first place that can happen is by both providers and doulas identifying those that they've already worked with, whether it's been a positive birth experience that one of your patients had with a particular provider, or maybe a provider group that you're already seeing is maybe referring to you as a doula, or that a lot of your patients are using, where you could kind of use that as the first venue for you to try to explore these relationships. So next slide, let's look at some of the specific tools. So this is the top portion of the doula invoice. We're actually sharing this to show an example of the introductory section of the document that provides the background and instructions on how to use this tool. In this case, because it's a sample invoice form, there's also some language around recommended invoicing cadence too. which helps you think about what considerations you should take into account as you're thinking about your partnerships. We'll look at the detail of the invoice form in a minute. But I also noticed there was a question in the chat about that cadence and when doulas would be paid. And it will really be up to you and the practice to determine what that agreement would look like. We do recommend setting a monthly payment schedule. Monthly, I think, is a way for you to aggregate information across the month. But I certainly wouldn't advocate for something like waiting until the complete end of the bundle reconciliation to be able to get paid, because we do recognize that doulas need to be paid close to when the services are rendered, and can't wait for that entire timeline to get any payment. Next slide. So this is an excerpt of the draft doula job description, and I'll note that it says draft on it because the document isn't finalized yet. This could help you understand what sort of qualifications a practice might be looking for and additional requirements that you need to meet or things that you could think about. We think that if you're interested in engaging in the bundle payment, it'd be an ideal first step for you to take a look at the job description to help you get prepared for what practices might be seeking from doulas. And the intention of us developing this document was to also come from a standpoint of seeing what would be appropriate to include in a doula job description, because a lot of practices do feel very unfamiliar with the role of doulas and what doulas should or should not be doing. And so this was really developed from a very doula positive, pro-doula standpoint of wanting to provide a document that could facilitate better understanding from practices about what the doula role would look like. Next slide. So now we're back to the invoice template. I know there's been a lot of questions about that $1,200 payment rate. So this, maybe potentially will help clarify some of that. So again, this document is in draft form. It hasn't been finalized yet, but as you can see, there's spaces for you to put in the expected information, such as the number of prenatal and postpartum visits that you attended. If we go with a monthly payment cadence, like we're thinking about, or like we've recommended, then it would be, ideally you'd be submitting this at the beginning of one month to reflect the work that you did in the previous month. So you might submit it on July 5th for all the work that you did in June. And it would represent how many prenatal visits you did, how many postpartum visits you conducted, and then how many births you attended. One modification that you might make is that maybe you won't split it out. You wouldn't split the births by vaginal versus cesarean, and you might instead group them all together for the purposes of your invoicing. And one thing that you probably are noticing that you don't see on this invoice is specific patient level information. And we do really recommend that you split out that type of information and only transmit that information through a HIPAA compliant source, and likely not through an invoice that would be submitted to like an administrator at the practice. Another resource that we provide in the toolkit is a spreadsheet where you could submit that patient level information if you and the practice ultimately decide that you want to be collecting more specific clinical information or like outcome information. Then we would recommend that you submit that patient level data on a spreadsheet through a HIPAA secure method, and not on this general invoice where you're just aggregating the visits that you did. Let's see here. So I wanted to mention that, these are just brief examples from the toolkit. As Darlene went over, there are a lot more resources that are included in the toolkit, and we do anticipate that it will be released in late July. And let's see here. So let's go to the next slide on how to participate. So how can you participate right now? I think in the short term, if you're feeling excited or curious about the opportunity to work with Husky members, we really recommend that you start by reviewing the DPH core competencies. Julia put the link in the chat earlier, and you could also review the legislation that was passed if you're curious. That link is also in the chat. And you can think about your training and how your background matches up with those expectations that are set through DPH. I also wanted to call out that Connecticut has several homegrown training organizations. Some of them I see are on this call today. They do a really phenomenal job in training doulas and would be a really great option for you to explore if you have gaps in your training and if you need to find a class that fills like a special, a single issue where you say, oh, I meet, 6 of the competencies, but I'm missing the 7th one. Really recommend that you leverage those Connecticut-based training organizations because they're really doing a phenomenal job of training doulas in your state and are a great resource. So as we've talked about, for the bundle, providers will set their own practice level requirements, but the core competencies are a really solid start. You can also begin to explore professional liability coverage if that's something that you don't already have. That is likely something that most, if not all, providers will require. And so we recommend that you start to think about that now and explore what your options are. There are just a couple of companies that are really used nationally by many doulas. And so it should be easy for you to find that coverage. And it is generally not exorbitantly expensive, though it is an additional cost. You can also think about the practices that you would like to work with the most, or maybe where you'll get started. And again, like I was saying earlier, think about who you're already, either enjoy working with at births, already getting referrals from, or notice that a lot of your clients are already working with, because those, might be good first stops for you when you're thinking about how to build those relationships. For doulas that are really looking to build their doula practice and have a lot of bandwidth, we would also recommend that you look at working with multiple practices. There's nothing in the Husky rules that precludes you from being able to have an agreement with multiple practices, as long as those practices don't prevent you from doing so. And so if that's important to you, I would say, talk to the practice and say, I'm going to work with multiple providers. And so I don't want my agreement with you to say that it has to be exclusive. But you could also, think about working with multiple practices. And the last thing that we wanted to note is that it could be beneficial to start thinking about either joining or forming a doula collective, where a group of doulas could work together to handle things like managing your credentialing, managing invoices and data tracking, because when you can pool your resources and maybe, have someone in your group that's like, hey, I actually love spreadsheets, I'll help with tracking this information. It could be great to work together in that way. And in our interviews with doulas and providers across the state, we found that there was a lot of interest in having a third party involved that could kind of be an umbrella organization. And then the last thing would be, when the toolkit is released, we'd really recommend you to just take a little time to spin through the materials and think about what they mean for you, and what the bundled payment integration, if you participated in it, what it would look like for your practice. So with all of that being said, I really want to thank you for your interest in the maternity bundle doula integration and for attending today's webinar. And we will open it up for questions. I know there's lots of questions in the chat, so I can start to look through those, but also if anyone feels comfortable, you're welcome to come off mute to ask a few questions as well.
I can, I've been looking at these while you've been talking, Claudia. And so one of the things I wanted to pick up on, I see a lot of comments about the one-on-one relationship that doulas and clients have, and that this structural way of paying doulas through the providers is setting up, a relationship that's not what doulas necessarily want, not what clients necessarily want. We fully understand and appreciate that perspective and have been working really hard to preserve as much of what we understand to be the secret sauce of the doula relationship, of having that trust, having that relationship-based care that can follow you even if you decide, hey, this provider's not for me, I need a different kind of care to get what I now understand my desires to be, now that I've been activated and had an opportunity to get educated. So we understand that these are really, in some cases kind of problematic structural elements. So I wanted to acknowledge those, say that this relates to the bundle pathway. And so the direct pathway, we are really grateful that that's going to be coming online now too. It will come with its own structural challenges. So I don't want to, but it will not require that provider supervision, and it will be a direct relationship with the Medicaid program. So there will be opportunities likely on the same time frame in terms of when these get implemented to work in different configurations. And I do think that there are some really fruitful ways that providers and doulas can work together and keep the doula, care really true to what doulas do, keep it patient-centered and family-centered. But it's going to require real team-based effort. And I would say that the being in collective and in community with other doulas is going to help on a lot of this. It's going to help with, negotiating power to work with these practices and make sure that the doulas are getting paid adequately and appropriately and in a timely manner and all of those things. I think having a collective of doulas and having some more organizational infrastructure can really help with those, and being able to look at your data and show it back to the practices. It will also help with that portability question of if you are a collective of doulas, you can create relationships with multiple practices, and then it will be easier to manage when a individual client wants to maybe switch from one practice to another. There also in our state are a lot of practices that seem like they're separate practices, but they're actually one practice umbrella. And so there might be some opportunities to work within, some of those larger practices and have a little bit of mobility for yourself and your clients to work with different providers around the state. Those are just some of my initial thoughts on those questions. I don't know if Claudia or Darlene has anything they want to add.
Yeah, I do see a comment that Precious made about some of these structural and systemic issues related to this setup, and noting that there is potentially some tension between keeping your doula if you're staying with a provider or switching to a different provider, but maybe not being able to keep your doula. And I think that's another kind of vote in favor of having a doula collective where you ultimately do have contracts with multiple providers, so that patients or clients would be able to switch to different practices and still keep their own doula. That is something that we thought about, we've raised, it's covered in the FAQs that will be released, because practices have that same question about what happens if the patient leaves my practice, and what happens with the doula. I think that it'll be less likely to be possible if you engage in a more employed model where you are employed by a practice and likely working just exclusively with that practice. But if you remain as an independent contractor and pursue agreements with multiple practices in your area, then you might be able to better float with a client if they do decide to switch. Someone else mentioned something about the invoicing and whether it would make more sense to invoice per patient as opposed to monthly. Absolutely. We think that, either if invoicing per patient felt more comfortable to you, then that could be a solution. Because oftentimes doulas require when they are working directly with a client, they require some upfront payment. We thought it was important to not set up a system where doulas had to wait until they had done all of the visits and until all the birth is done and the entire postpartum period is done, and then invoice for that patient, and maybe not get paid for any of your time until 6 or 8 weeks postpartum, but instead be paid as you're giving those services. And so that was the impetus for a 30-day invoice period. That's just a suggestion, and doulas and practices can work together to define what it looks like for their particular relationship. And if it felt more comfortable for you to invoice in a different way, then I think, by all means, that's kind of a good example of how you could take one of the materials and adjust it to fit your specific needs a little better.
I have a question. How are you, Claudia, and everybody? For the
Good,
report,
Cynthia. Good to see you.
hey, for the reporting of the outcomes, are they going to stratify that data by race?
Yes, it is stratified by race. There, that is part of the maternity bundle notification form that providers will be reporting race and ethnicity data of the patients. And in the current example form that we have for that information, we have a recommendation that that the provider not only collects the race and ethnicity of the patient, but also the race and ethnicity of the doula, to really look at how this doula integration, the equity of the doula integration itself, and what doulas are participating, because we do think that that's an important part of this program.
Okay, and is there any kind of assessment regarding the physician? Has that happened yet, where they actually have some kind of assessment about the physician's care, and how would there, if anything, and I don't know if it's addressed here or just with the physicians, how would the scope of their practice change? Because it looks like the doula scope of practice might change a little bit. How would, besides adding the doulas, is there anything else that's required of the physician?
So first I'll say that our focus, as consultants, our focus was on the doula integration, although we were participants in the maternity bundle stakeholder advisory group, and there's others on this call that are involved in that work that can chime in as well. But very broadly speaking, the bundle payment is meant to use the payment mechanism to incentivize providers to influence their outcomes. Doula providing the additional funding for doula and lactation support is one lever the DSS had to pull to help incentivize some of that practice transformation. But the other, lever is by using those shared savings, and how practices will be scored based on their outcomes. And I don't know the specifics. I can't tell you the specifics, but there is a webinar on July 6th that you can attend if you're interested in learning more about the bundle payment writ large. But practices will be scored based on their outcomes. It'll look at both historical averages and their particular practice outcomes. And practices that perform well, that have positive outcomes, or that are making positive changes in their outcomes, will be those who will have more shared savings, which basically means they'll get more money on the back end. Whereas practices that are performing poorly or not improving at all will not get those shared savings. And eventually, not in year one of the bundle, but in future years, it is expected that there will also be the flip side, or the negative of that, where they would actually be at risk for having to pay some money back. And in year one, specific to the doula payment, as we talked about earlier, if practices decide not to work with doulas at all, they will have to give back the money that they received that was earmarked for doula services. So the actual dollar amount that they're getting is $14 per patient per month for doula services. Mm-hmm. And if they ultimately don't end up using that, they will have to pay it back downstream.
Okay, and so is there some kind of rubric or something codified in the practice, in the procedures with the obstetrician or whoever the provider is, that would indicate exactly what is a positive outcome specifically? Are they counting the medical interventions, or if there's a C-section? How do they quantify that?
Sorry, my little pop-up came over as I was trying to unmute. So I don't feel comfortable. I don't have the expertise to specifically say what those are. So I don't want to say something that's incorrect. So I'm going to say that either, I see that Fatmata is on this call, Fatmata Williams from DSS. So I want to let Fatmata answer that question.
Yeah, no, but Claudia, you have done phenomenal in trying to explain. Hi, everyone. So there is not a specific rubric. We have the quality measures, and we will have to, look at how providers perform on those measures for them to determine, and that's all based on actuarial data analysis. And that's how we're going to be able to figure out who improved based on points, because all of the quality measures are weighted. Some of them are weighted high because, for example, the adverse maternal outcome measures is weighted 3 because we want to move that needle, right? So based on the points that the providers get, that's how we will determine, the savings that they're going to get. So that will all be calculated, but there is no rubric at this point. But I'm sure reports will be shared with the bundle managers. They may even share some baseline reports so they know where they're starting from. And then they could provide interval reports for them to see even how they're doing before the end of the program. And then during the retrospective reconciliation and calculating of who not necessarily win, but who improves, because the first side is just going to be upside, right? And then the first year, and then the second year is when, if you do poorly on certain measures, then you may begin to lose money. So that's the best I can see at this point.
Thanks, Fatmata. I see some additional questions in the chat. Are we looking at the same timeline for direct billing through Husky January 2024? That timeline is not defined yet. So we don't know if it'll be January 2024. I would think not any time before that, likely, based on how long it takes Husky to stand up that program. And other than that, it's not defined. And I did also notice, there's a lot of questions about when will we get paid? How much will we get paid? What outcomes will providers want us to check? And then I saw a comment that said, this is all about how you negotiate your contract. And I agree with that. This is really, Husky set some basic parameters for the program. Providers have, truthfully, a lot of leeway to define what the program looks like. What that also means is that you, as doulas and the experts in your field, have a lot of leeway to approach a provider and say, this is what your program should look like, and I'd really like to work with you, and here's the conditions that I have for what that relationship would look like. Come up with rates. I think that providers will be getting $1,200, $100 for each of those 4 visits, $800 for the birth. I wouldn't go and ask a provider for $1,300. They probably don't have that. But you could set a rate, come up with the job description that you feel comfortable with, define your parameters, and then really, we think that providers will be receptive. They're very curious about this, but they're also kind of like, we're not exactly sure where to start. So that's the idea of the toolkit materials. But you, as the doulas, are experts, and you are the ones that could really take the lead in saying, here's what the program should look like. Here's what I'm willing to work for, and here's the conditions. And there have been some, I know we're 1 minute over, so I want to be respectful of people's time. But I just want to say, there are some comments about wanting to be able to define that relationship with a patient or with a client first, and then go to the provider. That is technically a pathway that you could use and say, if you have a client that you want to work with, approach their provider and see if you could work something out. The risk would be that the provider, doesn't agree to whatever conditions you come up with, or that what they want to offer you find unacceptable. So
I know that we're almost out of time, but I have one more question, especially since Fatmata is on. And I'm looking at the chat as well. This is the problem. Well, and I've been stating this all along. Everybody knows how I feel. Because of the historical relationship between the providers and especially the Black doulas. And I don't think that there's very many Black doulas that, although they may be savvy enough and they may be, intellectually, they understand that they can negotiate. And I saw that comment in there. However, if it were that easy, I don't even think that we would have had to even been having this forum or have DSS or DPH or anyone else actually reach out to make sure that we can do that. Is there somewhere in this program that's going to address trying to get that relationship between the doula and the provider, and also, where implicit bias, anti-Black racism, is there anything that's going to be built in like that in this program for the providers? I mean, I know you may not be able to answer all of it here, but that's a major.
Absolutely, Cynthia, and all great points. And I see some of the, comments in the chat. And like you said, this is something that has never been done in terms of, bringing doulas and providers together. So this is, call it, that Connecticut is doing a pilot. We have some providers who are willing to try this and are working, with us behind the scenes, and are open to this because they also believe that looking at the integrated care model, even when doulas are able to build independently, for us to improve outcomes, they need to work together with the member, with that burdened person, woman, and the provider. So we are interested in, as we move along in the program, to connect providers to whether it's implicit bias training. So we know that those are being offered right now. Some hospitals are doing them. There's the Connecticut Hospital Association. Megan at one meeting said that they do have some trainings. It's a matter of putting together resources. So we are thinking about that because we do feel that it is important to move, not only improve outcomes, but also to address the disparities in outcomes. And it's clear, we are all aware of the data is out there. So yes, while we are not doing anything at this time, but it is part of the plan, even if it's just providing information about resources and encouraging and educating providers, whether through our provider relations, with our medical and other ASOs for providers to actually get those trainings. And I thank you all very much for the work you're doing. And I see that we're way, out of time, and I do want to respect people's time as well. Thank you.
Thank you so much, everyone, for your time today. And we really appreciate it. Great conversation. And you will be notified when the toolkit materials are available on the DSS website later this summer.
Thanks,
and just to let everybody know, we have a brief polling question to evaluate today's webinar. So if you can just take a minute and respond to those polling questions, we would greatly appreciate it.
I have to get on another call, Yvonne. It's with OPM. Wait, let me see what they're saying.
Adding them to the fee schedule for certain.
Yeah, I'll come down.
Feel free to log off. Thank you.
Thank you.
They're not enrolled individually. Okay, so when you say, like, you're talking about the provider.